Welcome everyone to the Indigenous, Local and Global Health Office's Equity Film Series. I'd like to start the event in a good way with a land acknowledgement. In the spirit of truth, respect and reciprocity, I'd like to honor and acknowledge Mohkinstsis and the traditional territories of the people of the Treaty 7 region in southern Alberta, which includes the Blackfoot Confederacy, comprising the Siksika, Piikani and Guyana First Nations, as well as Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. The City of Calgary is also home to Métis Nation of Alberta Region 3. Tonight's Equity Film Series featuring Switching Rhythm, a documentary that follows the journey of the Guyana Program to Advance Cardiac Care, also known as GPAC. I'd like to introduce tonight's moderator, Dr. Wayne Warnica, who is one of GPAC's co-founders and directors. He has worked as a consulting cardiologist at McGill University, University of Alberta, and University of Calgary, and is an emeritus professor of cardiac sciences and medicine at the University of Calgary. Tonight's panelists include Dr. Debra Isaac, founder and co-director of GPAC, and clinical professor of medicine at the Cummings School of Medicine. She is also the medical director of the Southern Alberta Transplant Program, clinical heart failure research program collaborator, and a mentor in global health program development and research. Dr. Sheila Klassen was a GPAC program coordinator where she focused on monitoring and evaluation as well as research components. She is currently a cardiologist with a subspecialty in cardiac ultrasound. She holds a faculty position in the program in Global Non-Communicable Disease and Social Change, Department of Global Health and Social Medicine at Harvard Medical School. Dr. Karen Then is a GPAC program coordinator and director of the GPAC Nursing Certification Program. She is a professor at the University of Calgary and an acute care nurse practitioner in Alberta Health Services in the area of cardiac surgery. She believes strongly in linkages between the clinical practice setting and her teaching and research. Haley Martin is Switching Rhythm's film director and editor. Her dedicated work in Guyana consisted of creating the documentary, informative videos, as well as a series of public service announcements to inform and engage with the community on heart disease. Currently, she is a digital media specialist with the Office of Advancements at the University of Calgary. Thank you to our moderator and panelists for joining us tonight and sharing your experience and knowledge. Before we dive into the discussion, we will watch the documentary, after which I will turn it over to Dr. Warnica. If at any time you have questions, please send them in the chat box. There will be time for a Q&A at the end. And if everyone can make sure their mic is muted, that would be great. You are welcome to leave your videos on or off. And now, Switching Rhythm.
Pretty skeptical. I thought, well, far away, long flight. We already have very busy lives, and I thought, do we really need to do this?
GPAC, or the Guyana Program to Advance Cardiac Care, actually started way back at the end of 2011 when I was asked to donate some echocardiography equipment to provide the ability to diagnose heart disease in Guyana. I was asked to do that with the vision by the people that asked me that if I just gave some equipment, that would significantly improve the ability to give care in Guyana. When I came to Guyana for the first time in January 2012, I realized, as I actually suspected, that nobody actually knew how to use the equipment. Nobody knew how to diagnose the images that were gained, so they didn't know what to do with results from the test, and they didn't know how to look after equipment. So we decided at that point that just dropping off a piece of equipment and hoping for the best was not the way to go. Now, I don't believe that you can do sustainable good if you just drop in every once in a while and use that equipment yourself. That would help a few people when you're there, but it doesn't help people in the long term. So the idea was that we wanted to make a sustainable difference. So I met with the CEO of the hospital, the Minister of Health, the Chief Medical Officer, and we decided that we should start a program to actually teach people how to diagnose heart disease with cardiac ultrasound. And then when we've taught them how to diagnose it, then it sort of slips into then how do you treat it? And then we could facilitate treatment. So the whole thing right from the get-go evolved around education for sustainability. I expected a pretty limited healthcare facility, and that's exactly what I found.
Anybody has been 1 star?
It was difficult to imagine how we were going to make a difference, and so we really started small. And initially I just came to help Dr. Isaac with the ECHO program, but there was so much to do, and there were people to see, and I could see more kinds of heart disease, severe heart disease in a week than I would see in a year, because Canadians are very lucky. We've got a health system where things are picked up early and treatment is available, and here they don't have either.
We found pieces of equipment all over the place that nobody knew how to use, nobody knew how to take care of, and they were decrepit and unusable. And that's why when I came here to donate the ECHO machine, when I realized that nobody here was going to be able to take advantage of it, that's when I thought, well, go big or go home. So you either do this right or you stop right here. When I realized what all I needed to do, I was flying home on the 1st of February 2012, and I'm thinking, whoa, what have I gotten myself into? Because I have agreed to set up a program to teach physicians how to do echocardiography to a high level. I've basically agreed to set up an echo lab, which means I've got to find donated equipment. I've got to have a curriculum to develop to teach this program, which is basically a 3-month program. I have to get volunteers to help teach it because we're teaching it on site in Guyana. I'm going to have to get support and money to get everybody here, plus all of the equipment. And I have to all do that in a very quick time frame because I had said that we would start by June 1st. The equipment got here and we had our first day of programming June the 4th. Our education program, again, started with the ECHO program, and that was what it was supposed to be. That was it. Then we branched out into, okay, let's teach them how to deal, not only how to do the echoes, but how to treat the patients. And then we recognized that we were seeing a lot of patients with heart disease, adults with heart disease, and a lot of heart failure. So our next foray was, well, we know that heart disease is an epidemic here. We know that it's not well treated and people come back to hospital over and over again. The patients aren't educated and they're not treated well. So let's teach the physicians and nurses how to deal with heart failure. So with the support of Dr. Mahendra Karpan, who is the only cardiologist that works in the public system at all, we set up a cardiology service. Well, you can set up a cardiology service, but you have to have people that know what they're doing. So from a cardiology service point of view, we identified a few people that were going to really learn about cardiology and really bear a lot of the responsibility for cardiology. So we started off with Dr. Terrence Haynes. We decided that we would start off with a 2-month cardiology elective in Calgary.
Since I was a little kid running around, my dad told me once, that was probably when I was 6 or so, he said he always wanted to be a doctor, but he never got the opportunity to. And since then, that stuck with me. And since then, I started to say I wanted to be a doctor. I wanted to help. And that has been through high school until I decided to go pursue medicine. That was sometime in 2003. Right, so it was my father's dream and it became my dream at the same time.
So he did cardiology for 2 months in Calgary to kind of get an idea of what's out there, what's the standard of care. And not only did they teach him what we do, but they also said, okay, these are the resources you have. This is how you use those resources appropriately to provide the best care possible.
I was there from the beginning. So when I started, a new unit wasn't established. We started with a little room up in the female medical ward. We were allocated a room with, that was 6 beds. Before in Guyana, all of the patients were managed by internal medicine, meaning there were internal medicine specialists with general medical officers working with them, and you never had subspecialties. So a lot of things were missed in terms of management on patients with cardiovascular disease. So by pulling these patients, we were more able to focus on them and follow them up and make sure they get the best care possible, which GPAC has been doing. Before, we never had a cardiac ICU. Now we have a cardiac ICU with 14 beds. We have a heart failure clinic. There's an area where we have an ECG lab. We have a stress testing unit. We have echoes. Those are things that were never available. So with the unit being there and all of these facilities or services being available, we have more and more patients coming to us, and we're seeing major improvements in terms of mortality. Our mortality rate has dropped significantly in terms of patients with cardiovascular disease, so it's had a great impact.
Now, I've just talked about the doctor's education. Well, other people need to be educated as well. The nursing education, now that we have a cardiology unit, has been expanded to a nursing certification program run by Dr. Karen Fenn, who is a professor of nursing at University of Calgary, who's also a nurse practitioner in cardiovascular, which is the perfect combination from our perspective.
So Dr. Isaac has been at me for a while since she started the GPAC unit with Dr. Warnica, and she's approached me actually a couple of years ago and says, Karen, I really want you to come and teach with us and work with us. And I said, yeah, okay, right? And it was kind of, that was it. And so she kept on coming back and said, no, I'm really serious. We need someone to work with nursing. And so I said, okay, when? And she goes, can you come next week? And so that's kind of how it started. So I got here with this preconceived idea about what I was going to do and had my stuff organized, and got here and said, okay, I got to put that all away and I've got to restart, right? So I literally I spent the first few days just being with the staff and seeing their knowledge level and seeing how they did certain things, and then actually went back every single evening and went and redid some of the training that I did and took my classes and changed them all so that it would be starting where they were at.
The hardest part is because of the fact that it's a specialty program. So we have to learn new things about the heart in depth very quickly, and also we had to quickly adjust and understand that it's life-saving.
I kind of had an expectation about where they were at, and then kind of went, okay, what we thought wasn't where it was at, so we kind of backed up and retrained them, and from then on I've been doing, every time I'm here, usually every single day, we do a teaching session. I try and do a PowerPoint up for them, we do bedside teaching with them, we do different types of scenarios, so we used all kinds of different formats for teaching.
It is interfering, but in a very good way, in a very good way. It has been an opportunity to really learn, and because of the fact that we do not really get a lot of opportunity, especially for free learning, we have been gaining so much and being better equipped to deal with our patients and give good nursing care, especially when it comes to cardiac care.
GPAC, you get to know the patients more, it's a bit more stable. Because the patients are long-standing patients, you get to know them personally. So if something happened to them, you know, it affects you because you know them. It's not just emergency or you treat them and they go away or they go to the ward. You get to see them every day, every shift. Sometimes you're working late and early, so you leave them sleeping and you go back next morning and you see them. You get to send them home happy. We had one particular patient, he was really sick. We thought he was going to die on us, but he got really better and now he's home.
There was a couple of moments where I realized, you know what, we're seeing stuff that I hadn't anticipated having to deal with. And one of them, a big one, was the amount of pediatric heart disease. We quickly realized that 40% of the echocardiograms we were doing were on children. And many of those children, in fact, 2/3 of those children had significant heart disease. And there's no option for them. There's nobody here in Guyana that really has any expertise in cardiac pediatric disease. They had no idea how to evaluate or triage these people, and in fact I found that many of the children were actually being given medications that were making them worse.
That was when we realized that we had to start an actual pediatric cardiology program, including educating the local pediatricians not only on how to do echocardiograms, but how to manage these children.
Okay?
Very good.
If you're good, okay? I'll give you this picture to keep, and I'll even put your name on it. What color do you want your name on? What color shall we put your name? That color? Okay. Your name is Joe, right? Kayla's a 5-year-old girl who was born with 4 things wrong with her heart. And those 4 things are fit in a classic pattern which we call tetralogy of Fallot. And basically what's happened is she's got blood going from one side to the other of her heart, so there's a hole in her heart. There's also reduced blood getting to her lungs, and because of that, her oxygen level is low. And that's why she's not as strong and not as energetic, because she's not getting pure red blood. It's mixing up. And you also said earlier that now she's got too much blood. Well, that means that too much blood is going from one side to the other, and one of those sides of the heart will get very big, and over time, if it stretches too much and if it's under too much pressure, it can fail. So that's why it's really important that we do this operation before it's too late, because her life will be cut short if we don't do this.
First of all, you got to understand the Guyanese culture, right? And it's different. And so my expectations of what a nurse does and how they are had to, when I got here, I had to revise that because I couldn't figure out initially why I didn't see the passion and some of the compassion that we would see at home with nursing. And so that was a little bit of a surprise. And finally one day as I was teaching, I just sat down with them and said, help me understand this. This is what I'm seeing and I don't get it. And they finally started opening up, which took a while, and they said to me, on the floor, we have 54 patients and we have 2 nurses. How do you expect us to be able to answer questions from family members or even many of the patients when we're responsible for doing all the care, all the dressings, all the medications, and actually have all of that done in a timely manner? It was impossible. So once we understood that, then it was like, okay, this is what we want to envision this unit to look like.
Last weekend, we were told that 31 nurses in the whole hospital didn't show up for work. And there is no penalty. It's a mess. On the weekend, we were supposed to have 3 nurses on, which is inadequate for the number of patients we had. Only 1 showed up. And so she was there all night with 11 patients that were very ill. And some patients were not adequately treated, but fortunately there were no deaths. But if it continues, there are people who are going to die.
I think one of the hardest things is to see people suffer tremendously. If we had had early intervention and prevention, they wouldn't be here. So seeing people a decade earlier having heart disease and dying from it, and having massive heart failure, which that's going to change their whole quality of life for the rest of their life, and they may never be able to work again, is horrific. It's hard. I remember the first patient, every time I came here, he was in his 30s and he had a massive heart attack.
When do you get the pain?
It's about, mostly in the night it happened.
Not when you're walking.
No,
Does it wake you up?
no.
What's the pain like?
Like just started swelling in my chest. On the 19th of March this year, I had a heart attack.
We spent 4 months here in the springtime, and he had a huge heart attack. He lives fairly far away, and by the time he got to a hospital and then was transferred here, he was really ill. So we had him in our interim coronary care unit for almost a month.
We didn't know each day if he was going to survive. And I remember one night praying and saying, please don't die on me today. And he came back and he saw me today and came and gave me the biggest hug and said thank you.
On his exercise test today, he did really well. And we did the exercise test because he was having symptoms that reminded him of his heart attack. And he was nervous, and I was nervous, because is this really, do we need to know another angiogram? What's going on? So we put him on the treadmill, and he did really well, and no evidence of ongoing ischemia. So that was reassuring for him and me.
We are in a third world country, and finances are not here. Medical was actually done until people like you know, Dr. Warnica, then put their input, and then everybody started to think, and now you can simply see differences around.
Oh, you look at Dora? You like Dora and Diego?
Dora and Diego. Let's go. Let's see what the balloon.
They have a painting of Dora and Diego in here.
Mama, a little quick kiss. All right. Let it go. Let it go. Are you ticklish? Are you ticklish? Are you ticklish?
Kayla is 5 years old, 10, undergoing computer repair today, bypass at 32 Celsius. Okay. Let's see, you have everything you need.
During anesthesia and during the initial parts of the surgery, she had a number of spells where her blood pressure went very low and her oxygen went very low. The team did amazingly well, got her on bypass immediately, the extra bleeding got stopped, and after that the surgery went really well. She was able to be taken off the breathing machine last evening with no problems, and she doesn't have any excess bleeding problems. Her oxygen levels are good. So Mom's pretty happy. Everything's going very, very well. She's had a complete repair, and she will need close follow-up, but the chances are she will not need another surgery in the future. So you're pretty happy about all of this, hey? Yeah. You said you were able to sleep last night for the first time?
Yeah, I was worried. It's very easy to worry, but you don't have to, right? Because they're going to get the best care, the same care that you're going to pay for to take them to a different country. You can have it right here in Guyana at Georgetown Hospital.
The team that's come in, the volunteer team that's come in, actually is teaching the nurses how to do procedures and how to look after these patients. So again, it's part of that whole teaching mandate. We don't just come in and do it and leave. We come in and teach, and every skill that they learn here, they can use to, in fact, improve the care of all their patients.
Today, we announce major steps. Today, we can boast that no citizen will be denied cardiac care because of their economic limitations, and no citizen should have their dignity shaken when confronted with a sick family member.
On behalf of the government of the people of Guyana, I take this opportunity to express heartfelt gratitude to the University of Calgary, especially to Dr. Isaac and Dr. Warnica, for all of the work they have been doing to improve cardiac care in Guyana. Dr. Warnica and Dr. Isaac has demonstrated to us what is being human rather than just being a human being.
The CICU opening is basically a recognition that we have a full, proper cardiology service here that is giving high standard of care, and it's giving this care to the public at no cost.
The program is here and it's here to stay, and it's acknowledgement by the hospital, by the ministry, that this is something that's needed and recognized. And that's huge. The recognition is huge. All of us, none of us are doing it for the recognition for ourselves. That's not why we're here. We're doing it for Guyana. We want the people to be recognized.
We have come a far way. We've had many challenges, but we still have a far way to go. We have reached this stage and we can reach higher.
The most rewarding moments are when I see patients that I know would not be alive or would be in very bad shape if our program didn't exist. We're going to take really good care of you, I promise. I promise. And it's not that Dr. Warnica and I are doing these things personally for each patient, but that what we've developed as a program and as a team has made a huge difference in people's lives. I look at the 84 children that have had surgery that would not have had surgery. I look at the hundreds of patients who've had heart attacks and who've had heart failure that would not be either alive or doing well.
You're making progress.
It is really rewarding when you see those positives, right? Or when you help someone that is just trying to understand about why this happened to them, right? So heart disease is huge here. It's huge. People don't realize how much heart disease there is. And most of them are realizing too late.
It's so important because what we're trying to build is a healthcare system that treats the patients as well as they can within the finances of the country. We're teaching them that we can provide care to people regardless of their money. But it's also really important that we're providing education to doctors and nurses so that this isn't just a one-off. This is going to be a sustainable program. Our whole goal is to work ourselves out of a job so that they will come to us and say, thanks very much, but we don't need you anymore.
There were lots of obstacles and hurdles along the way. So to know that we have all of these things there and the patients are there and they're being cared for, it makes me happy. I smile. every time I go in the unit and say, oh, we've gotten this far. We still have a lot more to do, but the fact that we've gotten this far is great.
Okay, so I'll turn it over to Dr. Warnica now to start with the panel discussion.
Thank you very much, Lindsay. I was trying to be a good boy and keep my phone muted. Dr. Isaac gave you a brief story of how we started this program. And when it started, as she said, it was something small. But once we got there and realized the scope of the problem and what would be needed to make a difference, we began to search for funding. And one of the things we had to do, if we're having funding, then we had bills to pay, is have a place to put the money. And that's where we came up with the term, the Guyana Program to Advance Cardiac Care, that we started, and we have a number of co-directors that help us manage this. A vital part that we didn't mention, well, it was touched briefly, is the role of the volunteers. We have had, throughout the program, we have had an incredible number of dedicated, generous, kind, considerate volunteers. Doctors, nurses, technologists came down and volunteered their time. And almost everybody who's been can't wait to come back. As Dr. Then pointed out, you get hooked and you see what can be done. I mentioned funding briefly, and this is not a cheap program. The equipment is expensive, the flights are expensive, and we very much depend upon donors to survive. We were supported by the University of Calgary, the Libin Foundation of Calgary, and other donors. More recently, we have gained the support from the Rotary clubs, our local Calgary clubs of Rotary Olympic and the Downtown Rotary Club of Calgary, and especially for the Dr. Steve and Mary Turner from the Club of Olds, who are really the drivers behind this program and getting the progress going. And we also have support from the Rotary Club of Guyana, who are supporting and working with us. So with their support, we have quite a significant grant from Rotary International that we hope we'll be able to continue on for several years. Because as you heard throughout the video, we still have a lot to do. And there's so much teaching, and as Dr. Isaac said, sustainability through education. And unless we teach people how to manage it, this program will not be sustainable. I'm going to move on to the panel discussion now. This is going to have a couple of rounds at the question mark. Before I introduce the panel, though, I meant to introduce our son, Stephen Warnica, who was the executive producer of Switching Rhythm, and he has been to Guyana 4 times and knows the country and knows the system very well. And he's in the audience tonight, and so we'll put some questions to him as we go on, and he'd be happy to answer questions from the audience as well. I'm going to start the questions on round 1 with Dr. Isaac. I guess since we've been married 30 years now, I can call her Deb. Deb, you mentioned in the film that the initial step you took was required meeting with specific leaders from the Ministry of Health and the hospital. Why was that so crucial to the success of this endeavor? You're muted.
Oh, okay, sorry. As I mentioned in the film, I was actually invited to Guyana, and I think that was critical to have somebody ask me, not for me to kind of go, you know what, I think I can help somewhere and I'll find a country. So the fact that I was asked to go there, even though I was asked, quite frankly, to go there and give them a piece of equipment, I think that was a good entree into it. When I recognized that, which I mean, honestly, we would all know that ahead of time, that a piece of equipment doesn't change healthcare, it never does. But I thought I'll go down there and see what's going on. And when it was indeed that way, I recognized that I couldn't just decide, well, I think I'm going to fix things here. And I was very fortunate to be able to meet with the Minister of Health, the CEO of the hospital, the Chief Medical Officer of Guyana, and everybody was there because of a connection that I had that had asked me to go there. And it was in this very long, several-hour meeting that we discussed what was going on. And in fact, what I was able to do by sort of explaining why leaving this equipment wouldn't help, and talking about what are their goals when they were talking about sustainability and how they want to move forward and be sustainable, that's when we talked about education. And I think if it hadn't have been for that first meeting and get everybody in there recognizing that they had the opportunity to do something that was sustainable, I don't think it would have gone very far. And interestingly enough, when I left that meeting, that's when my moment was like, what have I just agreed to? But the reality was that it came from everybody else. And so I think that is absolutely critical. So you have to have partnership. You have to make sure people don't think you're coming there to do stuff to them or for them. You have to make sure that you are addressing what they feel is their needs, because when you start pushing the boundaries and pushing for stuff and nagging and getting stuff moving after that, they can go back to the fact that really they were involved right from the start and it was their idea.
You mentioned partnerships. They've certainly played partners with our volunteers, partners with the hospital. What about partnerships?
Well, I think that you have to approach this as a partner. And again, establish that partnership with the CEO of the hospital, with the Ministry of Health. And you also then need to identify and Karen will talk about this, but trying to get the other people that you're teaching, the Department of Nursing, everybody else, actually seen as a partner, not you are providing them a service or you're doing something for them. So I think those partnerships at all levels are important.
Thank you. Karen, you mentioned in the video the differences in nursing culture and nursing care, and the role of compassion. I know we've talked about it before. Can you tell us a bit more about what it's like to train in those circumstances?
I think that what was really key is to go there. I had a preconceived idea about what nursing is and what nursing does. And when I got there, what I expected to see of nursing wasn't there. And, you know, I really needed to step back and, like Dr. Isaac said, is look at what the agenda is and look at what their feeling is important there. And so that's what I did, is actually step back and then start to explore about why is it that nursing wasn't compassionate, or why is it that they weren't going out of their way to help their patients, and understanding that their teaching, their education was so different, and the expectation of a nurse was more to be a servant versus it was that they had an idea that they could present to a team and work with it. So the partnership had to go with nurses, it had to go with the aides, it had to be the administrators, and it had to be physicians. So the education had to go in a round robin to actually look at all those components and start to empower people to say their knowledge and skills are really important, and we needed to empower them to embrace looking at the situation and giving their own ideas. So it was a real team effort from everybody that's involved.
Did you, I think I know the answer to the question, but could you talk about the changes in the knowledge base and particularly the attitudes of the nurses in cardiac intensive care unit?
Yeah, so at the beginning, what I decided to do is when we went down there is to do a little bit of a survey. So we did some research and looked at where their knowledge and skills was at the beginning, and then did it a few months later, and then do it 1 year later. And the changes were astronomical in their ability to not only know the information, but to actually be able to portray it to patients and family members. And that took a lot of mentoring, in the sense that many of them had never been given that opportunity. So we did things with physicians, we did things with myself and for other volunteers that were there, and literally sat down with them at a patient's bedside and teach them how to react to a bad outcome, or how to actually portray that and give that information, and how to support people when there was a loved one that has just died.
Thank you. Haley, you, as we know, you had a major part in putting the film together and doing the filming, putting it together, and then editing. The other thing that we haven't mentioned so far is the public service announcements that you and your group prepared for Guyana. Why do you think you wanted to do the documentary? Do you think it had an impact on GPAC? What about an impact in Guyana?
Yes.
More importantly, what was the impact on you and your colleagues?
It's a kind of crazy that it's been 4 years already. It's a good feeling that we're still watching this documentary and it's still provoking thoughtful and meaningful conversation. So that was kind of our goal, I guess. So I think I can easily speak for the rest of our team that we worked with, that it was a really extremely rewarding experience. There was something really special about GPAC that kind of stood out from other mission programs, where they weren't just coming in, helping for a period of time, then leaving. They were going in to make sustainable change, because that's great to offer help for a moment, but what happens afterwards? What happens with those new patients and even the existing ones? What happens with the follow-up there? And that the sustainability was the part that's lacking. So, but with partnership and education, as core, GPAC was building a sustainable program for cardiovascular healthcare. And not just implementing it either. They were building it with the Guyanese. They were creating something from where they were at and taking their input as to what would work with them and their environment. So not only did this program hold like a very inspiring journey to tell, but I feel like I was given with my particular skill set the opportunity to give someone else the stage and amplify their voices and spreading education and knowledge in a certain way on some really incredibly major issues, and hoping that kind of inspires someone else to maybe take on the same idea of using education to build sustainability and maybe be a part of GPAC to lend their knowledge and so on. But as you mentioned earlier, Stephen is also here. And so I'd kind of like to pass on the question to him. Being as the first person who had this idea, you brought me on, which I'm forever grateful for. And you kind of had the original focus of doing a documentary on education and sustainability. So what compelled you to do this?
Well, one thing I should be mentioned is I worked on another documentary of similar sort of focus about GPAC and their work with International Children's Heart Foundation earlier that year, and it was primarily focused on really the work with the kids and the work with Baby Heart themselves. And having been, hearing about this program and learning about it throughout the years, and then going to Guyana and seeing sort of really what it was all about, I thought it was more important. And really the bigger thing to focus on with GPAC is the education sustainability aspect, because that's the key thing that makes it the most different and really important comparatively to other programs around there. So that's really where we started, and having several conversations with my parents and sort of really bringing that together, that was the basis for it.
Okay, thank you. Sheila, are you still with us?
I'm still here.
Oh, good, thanks. You worked a lot with training the physicians at GPAC, and you and your husband were also invaluable in preparing a database. And you're continuing to do research with Dr. Isaac about the progress. What we have found with the database that you and your husband have worked on and we're following up, we now have a sort of an electronic medical record, because as you know, when we first started, there were medical records were a mess. Every time a patient came to the hospital, he had a new chart, and you just couldn't find out what was happening. Now we have a database of all the patients who've been admitted to the heart failure clinic and the CICU and the heart failure in the cardiac service, so that when they come back, we have access to their records, and it has been a tremendous effect. One of your research projects has been evaluating the program. Why do you think that's important, and what the role of the research is?
Yeah, thank you, and thanks also for to the organizers for inviting me on this event. I think research is really important, and as you had mentioned, Dr. Warnica, when we were there, kind of 6 years ago, dealing with the paper charts was just impossible. Not knowing what had happened in a previous hospitalization, not knowing what medications people were on, having these paper charts, not filed properly, and you couldn't find them the second time, and not knowing what had happened the previous hospitalization was just frustrating, and was not good care. So I think, so just to give some background, we kind of built this online repository in 2015, password protected, and it was just a way of storing patient data and having it exist so that people could access it. And, the power goes out from time to time, the internet goes out from time to time, but when it comes back on, your data is there and you can access it. And it's still a lot better than paper charts that can get lost and dropped and that sort of thing. And as you had said, people can go back, providers can go back and look at previous hospitalization data and medication lists, which are really key for us in clinical practice. And then we also built it such that the data could be exported into an Excel spreadsheet. And so that kind of brings us to that second part of that question, the concept about monitoring and evaluation in global health. So we're always in global health, I think, taking things that work in one setting, in the setting that we know, and trying to apply it to a different setting. And, how do we know if it is, it's working? Oftentimes, depending on our own backgrounds, we make a lot of assumptions about how healthcare is delivered. And this is what Karen had said before. You kind of take your own experiences and you kind of assume that this is the case for this new environment. And I think an integral part of healthcare delivery and global health delivery is knowing what's effective and what isn't for each context that we work in, and not taking a cookie cutter approach for all our projects. And also, I think having some of that data and presenting it and making it known gives everyone involved kind of a collective feeling of responsibility around gaps that are identified. And everyone kind of feels this, oh, this is an identified gap. The data tells us this. How can we address it together? And then publishing on it is just kind of a way of sharing our experiences. So, as you mentioned, Dr. Isaac and I are working on a paper right now on kind of the 10-year GPAC experience, and kind of sharing that with the world, and hopefully people will also benefit from that.
Yeah, I think I'd just add that if you can demonstrate where you were and where you have been, you can demonstrate to the powers that be that pay the bills that we're actually accomplishing something and making a difference. And you can't do that without research. Thank you. We're going to have a short second round of questions, and then we'll open it up to discussions from the audience. Back to you, Debra. We've talked about the evolving of the program, and you've really been the driver behind this whole project. Your ideas and your energy have kept it going. How did you think about all this developing? How did this work out in your mind? You have to mute.
Yeah, no, the button wasn't working, but okay. Anyway, so yeah, again, as I mentioned before, I didn't start off thinking about this whole project, and if I would have run for the hills. But part of it was you start with one thing and you recognize a need, and the biggest important thing for me is you engage with the people. So, for example, Dr. Haynes and the doctors that were there, and the fact that they were so keen and so interested and so appreciative. The fact that people like Miss April, who all of you who will know who's there, who's our sort of local coordinator, the fact that you've got somebody there working on the ground so hard and so willing to do stuff makes you want to take it one step at a time. So again, we have recognized the heart failure aspect of it, how much there was. Well, there were people there that were just so willing and wanting to be able to do more for their patients. And then I got somebody from Calgary who's a heart failure nurse, a couple of people, and they came down and they got so keen, and they made really connections with the nurses and the physicians, and got them all excited. And it sort of like it rolls, it keeps rolling. And yes, I was sort of the quarterback of it. But when you look at the pediatricians who were having to watch all these kids die, and you're able to sort of teach them something that will help them diagnose it. And then the next step was, how do we make a partnership to help with the children? So being able to connect with the International Children's Heart Foundation and convince them that they should come 4 times a year, for 3 to 4 times a year for 2 weeks, and bring the team and operate on kids, they only did that because we shared a philosophy of education and sustainability. So again, develop those partnerships, develop like-minded people. We do not want people to come in and spend 2 weeks in volunteer tourism, medical volunteer tourism. We want people that really want to connect. One quick point I should say is, because Guyana is not really a tourist mecca, doesn't have a lot of big beaches and stuff, you know, people who come there to work don't come there to lie on the beach.
It'd be tough to find a beach. Before you go, what would you tell other people who are thinking about starting a project like this? What have you learned that you could tell them?
Well, I think what I've learned is that you have to go in there with no set ideas. You have to form partnerships immediately and make people think, make them know that you are working with them and that you're going to engage them. And, you know, one of the things that we've done, and Sheila, of course, knows this very well, is we've also pulled them into our research projects and saying, look, we want to evaluate this with you. And so again, make those partnerships right from day one, go in there and do that right off the bat.
Thank you. Back to you, Haley. One of the things that we strongly consider, you know, when we're building a program like this in countries, and it's almost always third world countries, where we don't live in, and we're not very familiar with community engagement. What was your role in getting community engagement, enhancing the community and stakeholder engagement in the process? How would it affect the establishment of partnerships? And how did you and your team prepare to not perpetuate stereotypes of the white invasion?
Yeah, so in the film, when Karen speaks about how she came in with a plan to teach the nurses, and then she got there and he was like, okay, you know what, we're completely scrapping that because we have to start at where they're at. And I feel that was almost kind of like a take that our team did as well. Planning for this trip, we didn't really know what we were getting ourselves into. Stephen had already been there, of course, before, but you try and come up with a plan on how you're going to write this. Which is kind of an unrealistic approach, right? Because it's a documentary, you got to see what you get when you get there. But yeah, Georgetown was a very different place from Calgary, so we kind of had to take a step back and soak it all in and get to know people that were at the hospital. We talked to the doctors and we got to talk to some of the patients and the nurses and just really get a sense of how they saw the healthcare system there, because of course, like, we got the take from yourself, Dr. Warnica, and Dr. Isaac plenty of times, but it's another to get it firsthand from them, right? So with Switching Rhythm, we wanted to approach it with the most authenticity of the program itself, as well as the utmost respect of the Guyanese and their culture as well. So it was important to show that this wasn't a program that forces all your rules on them. This was where you were starting where they were at and using the tools that they had at their disposal. And going back to respect, like, there's kind of parts in the film, like, for example, when we speak about the nurses not showing up to work, and that wasn't in a way to discredit their hard work or disrespect them in any way. It was to give impact and show the difference of, like, where we are here and where they are there, that nurses shouldn't be working 2 jobs, that they shouldn't be overrun like that. And that's just kind of where they were at with things. So in the process of making the documentary, talking with the staff and hearing patients' stories, that health literacy was very poor and it was an issue. So that kind of led us to talking about how we can do more engagement within the community. And we got to the area about creating the public service announcements. So we, just from talking with people and doing the documentary, we know that the Guyanese didn't know how big of an issue cardiovascular disease was. They didn't know the signs and symptoms of a heart attack, serious issues that could be prevented if caught early. So even if they knew something was wrong, there was also so little trust in the healthcare professionals that people would just avoid the hospitals altogether. So we wanted a way to bring light that you can trust your doctors, that these are the signs of a heart attack and they can take care of you. And in doing that, we wanted to show the faces of people they would recognize. So this was local doctors, this was real patients, these were recognizable Guyanese faces as well. And you know what, I feel like Stephen could maybe speak to this a little bit more, just because he played a huge part in organizing all these people. We had very different roles in this whole process, but they were very key roles, just identifying who we should involve and why we should involve them. So Stephen, would you mind touching on that a little bit?
Sure, thanks, Haley. Yeah, like one of the key things, you know, it goes back to the white savior complex as well, as like, in order to reach people locally, you really want to, you know, have people that they recognize and they know who they are and that they respect, to really, you know, let the message sink in. Like, you don't want to have people that they don't know of, you know, in this case, especially people who are very evidently not from Guyana. You know, when you have people who aren't from the country, you're going to lose their sort of respect in a way that they won't think that you know what you're talking about as much, because they, you know, we don't understand the local issues, like, you know, that kind of thing. So, you know, when we approached, you know, celebrities like Dave Martins, who was a huge help as well, and, you know, like well-respected figures like a really, you know, respected lawyer named Nigel Hughes. Well, they were super motivated to help out, which was fantastic to see. It really took away a lot of the stress of the situation, but it also allowed them to really give insight into what they think would work and how to word things proper, like word things in a way that people might understand. And yeah, I think that was really key as to why the public service announcements were well received and as far as I know, continue to be used as well.
Good, thank you. Karen, back to you. You put a lot of time and effort into this. What have you learned from all this process?
A ton. You know, when you reflect back and when I was thinking about, you know, this whole process, I really have become more sensitive in understanding my own cultural biases and beliefs for myself. And that's been one of the key things actually going in and working with the nurses, is to understand all of our cultural biases and our own belief system, and actually using that to our advantage. And once we reflect on the way we are in our belief system, then we can move forward in such a positive way. And part of that was really understanding the local context and really moving that forward, because once you understand where they're coming from, it's easier to help them come up with a path about where they want to go, because sometimes they know what they want, but they don't know how to get there. And so our role sometimes is just helping to facilitate that through education and knowledge and building up and empowering people to become that. So really checking our expectations at the door and making it the people's expectations, and our staff and our nurses and the physicians and the patients, what is their vision and how can we move forward?
Good, thank you. Finally, Sheila, you volunteered with us during your cardiology fellowship, and you spent a lot of time, and since then you've gone on to work in other countries. What do you think are some of the implications of projects like this, like GPAC?
Yeah, thank you. It's been a while, you know, thinking back, it's been, you know, 4 or 5 years since cardiology fellowship, but it's been such a wonderful experience, and I learned so much kind of carrying that forward into my other work. And there are, I think, things that have come up time and time again, lots of different things, I think, but I think the concept of partnerships keeps coming up, you know, both in our discussion and just everywhere that I've worked since, you know, in Rwanda and Malawi and Liberia, just this concept of strong and equal partnerships, and just, you know, being there, spending the time, understanding the needs, and just engaging with people, you know, taking the time to build those relationships, I think is key. And we've you know, discovered that with GPAC. We've talked about it tonight with GPAC, but it's true anywhere and everywhere I've been. So I think that's one of the key things. And then secondly, just, you know, my bias, but I'm always this very strong supporter of a data-driven approach. And I think that's also come up in a lot of my work since GPAC, is that taking data, you know, it's not just kind of the sake of writing papers to publish them, but also using that data for quality improvement within the projects that you work in, driving the directions of the projects that you're involved in, sharing that data with other people who are doing similar things. I think all of that is really valuable to improving our work, both kind of locally or wherever we're doing work, as well as with the wider global health community. So I think those would be the two things that have really resonated with me, both in GPAC and since then.
Sheila, I just wanted to comment that I see Mikhail is on the conference call or Zoom call as well. And Mikhail actually built this database out of nothing and put in many, many hours as a non-medical person to make this happen. So Mikhail, I just want to take this opportunity to thank you so much because we would not have been able to do what we've done without you. So thank you.
Thanks, Dr. Isaac. It was a very interesting experience for me to be able to do that. I didn't know very much going in, but the experience of doing that and building that database, which I had no business doing, right? There are professionals who would have done a much better job than I did, but it's humbling to see that it's actually done so much good and helped so many people.
Thanks, Mikhail. Quick question for Karen. And you've talked about all the volunteers that we've had. Did it ever reach the point when you saw Dr. Isaac coming down the hall toward you that you thought you should go the other way?
I guess I should have done that before she asked me and I agreed the first time, right? Because yeah. Like I said in the film, I mean, once you're there and you see how much fun it is, it's fun to actually see someone learn and want more and ask you for more and what else can you do or what about this. It becomes a wonderful experience. And I've got many nurses and other people that have already come to me even in this pandemic and said, what can we do? And we're arranging Zoom teaching for them from pharmacists, from other nurses, from other educators who all want to be in some way, even if they can't ever go, that to facilitate some of their ongoing education.
That's fantastic.
I should mention as well that Karen has developed a 2-year bachelor's degree program in cardiac and cardiovascular nursing from the University of Guyana. So it's actually a 2-year program in cardiovascular nursing that has been approved by University of Guyana. Now, University of Guyana is not actually going to be teaching it, it's Karen, but just to let you know, that's the level, that is the level of teaching that she's been doing.
And there's lots of nurses wanting to take it, so which is fabulous too.
Great. I think, Lindsay, we have one question, but feel free if there are other questions. Joe asked, do you think that the hospital situation would be different if Guyana was still under full UK control? Even though it's part of the Commonwealth, it seems to have been lost in the system of support.
Well, I think, in fact, it would, but again, it's hard to know for sure. I mean, obviously, they're very happy to be independent for just over 50 years. It's my mother. She's going on ignore. Anyway, they're very fiercely independent, but when I look at Suriname, and which is the neighboring country, when I look at that, they are still under, really under more control or more partnership with the Netherlands. And they have a lot more access to training for their people. So they may not have all of the bells and whistles in the country, but they do have access to more education. So in general, when we've been there, we've found that their medical staff are much better educated. So I think that might have been, having that connection would have been good.
Any further questions?
I actually have one for the group. At what point do you consider, or do you even consider, perhaps underlying causes or the determinants of the health of the Guyanese people? The community, the Guyanese, identified the need that they needed to help their patients with cardiac health concerns. When you got there, you noticed that there's a particular issue with children. But then at what point do you look at, well, why is that the case? And if you did, do you incorporate anything to address that, or is that just beyond your scope and scale?
I mean, you should mention that. We have actually done, again, thanks to databases, et cetera, we have been working on trying to identify why we're seeing so many children. In looking at some of the work we've done, again, evaluating that, we also realize that the kids we're seeing very late in their illnesses. So now we've looked into how do we identify these children early. One of the things we've done is set up we have a neonatologist in the neonatal ICU that now does echoes. We have echo equipment there, and she actually has learned how to do proper echoes, and we have a connection with the pediatric cardiologist in Suriname and with Gift of Life International, so we can now start identifying these kids early. We did a couple of years ago, we tried to do a study and looked at all of the kids that were referred to us, because we are the only really pediatric cardiac center in the country. We looked at all the kids that were sent to us. We evaluated, again, that's how we found out how late they're being seen. We also looked at what area of the country they live in and how can we do outreach. And the other thing, we then tried to compare the people, because we keep thinking they're coming out of the woodwork. In fact, every single week, including this week, I've had 2 more significant echoes sent to me for these kids. So we looked at that, and we looked at the birth weight rate, and we tried to look at the government records of birth and trying to figure out what percentage of births have this. Well, the government has no really good registry of births even. It's not even consistent. And we also know that for every child we see, there's probably half a dozen out somewhere else that nobody is identifying. So what we've done is we started working with the more rural places to try to identify ways to do education with their healthcare providers there, how to identify these kids. And again, with the public service announcements, which we haven't obviously shown today, the public service announcements go out to all the areas to say, this is what we have. We have a pediatric cardiac program. If you're a healthcare provider or a parent, don't be scared, come and see us.
Thank you.
I did have one more question. If there's, I don't see any other from the audience, but this would be for Stephen and for Haley. When you were taking pictures and taking the videos, how did you approach people to ask for their consent? We know that's a huge part of making documentaries and films and even taking pictures in general. So how did you tackle that?
I can answer that one. Yeah, luckily that's a pretty like common thing here, so it's not something where I don't think you're abnormally uncomfortable with doing. You know, you have things like, you know, like consent forms and whatever. To my recollection, like, you know, just approaching people and kindly just describing what we're doing, and you know, if they have any questions about it, it was usually the way that worked best. You know, people, for the most part, once they heard about what we were doing, we're more than happy to, you know, provide that consent as well. So, you know, we were very fortunate to not really have any issues with that.
I remember even when we were in the unit, it was the same amount of patients pretty much the entire time we were there. So like even on the first couple days when we were settling in, grabbing additional B-roll and such, we kind of just got introduced through the nurses and the doctors and the team, and just kind of describe what we were doing. And from their point of view, seeing it as a way of education, and that they were getting better, and that they could hopefully inspire someone to trust the doctors and to come in. Everyone was on board. And if anyone was against it, then we just made sure we never had the cameras pointed at them.
Thank you.
Ahmed, I was wondering, again, we have Dr. Abdi Ali is also on the line, and he was talking to me earlier today about looking at wanting to do something in his home country of Somalia, and explained to me a little bit how poorly resourced they are in terms of healthcare expertise. Ahmed, is there any questions or comments that you have for us?
Dr. Isaac, first of all, really, it's very inspiring what you and Dr. Warnica have done, and it's amazing. You know, to think how things sort of an idea that you had from just being invited to help donate equipments has changed a lot of people's lives. And yeah, I left Somalia when I was 6 years old, and so I don't really know a lot about the country. My grandmother and my aunts still live there, and so I went and visited for the first time about 2 years ago. Just before the pandemic, the COVID pandemic started. And they're from northern Somalia, which is sort of a little bit more stable than southern Somalia. And what kind of really was very heartbreaking was the lack of care. And essentially, the whole northern Somalia only had one cardiologist who was a retired guy from Turkey, who's now established a practice sort of about 6 months of the year. And he, in his office, had essentially one working echocardiogram, and that's what he was using to sort of look after the patients. So having seen, you know, the lack of care, and that sort of got me thinking about how I can help, how I can provide any help. It's very overwhelming, obviously, and I'm sure you know this from when you started this. I came back, and I have two of my siblings who are physicians in the States. One is an internist and one is a GP. And we're thinking of doing something, but we don't really know how to start, and we don't really know, you know, who to partner with. And so that's why I wanted to talk to you and seek your help and advice. So that's really inspiring what you guys have done. The difference between Guyana and Somalia is, at least Guyana is a stable country, and so with stability, obviously, comes people or partners who can come and help you. And in Somalia, that's sort of not the case, and so that's the challenge.
One of the things we've learned over the last 15 months is how to do virtual education as well. And so we're providing a lot of virtual education. It will never take the place of hands-on face-to-face, but it certainly is a way to start. And, you know, we should talk at some point, you know, in the next little while about how some of the things we've learned and maybe some of the programs we've developed could be helpful for you.
I appreciate it. I will. Thank you very much.
And the other thing, I keep butting in, but the other thing is I wanted to say hi to Ria, who has joined us. Ria Jota is a medical student from Stanford who is actually Guyanese and who's working with us on one of our research projects. I think she just left. Did you leave, Ria?
I'm still here. I'm still.
There you are. Yeah, so Ria again is from Guyana and is working with us on our research project that we're doing on maternal pregnancy and heart disease. So the maternal health, lots of heart disease in pregnant women, and we're going to do that project. And her plan is to make a big impact on Guyana once she's done her medical school and residency training. And so we're looking forward to having a very long relationship with Ria. So thank you so much for joining us.
Yeah, thanks so much for having me. It's been great to hear all of you guys speak.
Lindsay, are we finished, do you think?
I think I don't see any other questions, and it's right on time at 7:30. So again, thank you everybody for joining us tonight, and thank you for sharing your Monday evening with all of us. And the session was recorded and it will be posted on our website, so it can be used as a resource and tool for later, and I'll make sure that everybody has that link. So thank you.
Thank you. Thank you all the panelists. Great job.
Thanks for the invite.
Thank you, everybody.
Thanks, everyone.
Bye.
Thank you.
Thanks, everyone. See ya.